Hello, everyone. Today we're going to be talking about social determinants of health and how they differ within the context of Indigenous populations. The objectives are: list key health indicators for American Indian and Alaska Native, including characteristics of mortality and morbidity specific to AIAN, and population distributions and pyramids. Demonstrate how concepts and ideas drawn from medicine and epidemiology were used to support the process of colonization of Indigenous peoples. Identify and demonstrate the impact of social determinants on Indigenous health, including specific health issues uncommon to the broader population. Assess the strengths and limitations of available data used as key indicators of Indigenous health. Explain the impact of culture on prevention, definition, diagnosis, and treatment of illness. And identify the key principles of successful health surveillance, including partnership, ownership, consultation, and action research. Social determinants of health, SDOH, are non-medical factors that influence health outcomes. They include the conditions in which people are born, grow, live, work, and age, as well as the systems that shape daily life. These factors are important because they can have a greater impact on health than access to healthcare or genetics. Indigenous peoples approach health as an equilibrium of spirituality, traditional medicine, biodiversity, and the interconnectedness of all that exists. This leads to an understanding of humanity in a significantly different manner than non-Indigenous peoples. According to census data, the majority of the American Indian and Alaska Native population in the United States resides in the western states, with the highest concentrations found in Alaska, Oklahoma, Arizona, New Mexico, and California, with Alaska having the largest proportion of its population identifying as American Indian or Alaska Native due to its large Alaska Native population, followed by Oklahoma and New Mexico. Population pyramids for this demographic group show a younger age distribution compared to the overall U.S. population, with a larger proportion of individuals under 29 years old. Some key points about American Indian and Alaska Native population distribution are: regional concentration. The West region of the U.S. has the highest concentration of American Indian and Alaska Native people, with states like Arizona, New Mexico, and California having significant populations. Alaska dominance. Alaska has the highest percentage of its population identifying as American Indian or Alaska Native, largely due to its large Alaska Native population. And Oklahoma significance. Oklahoma has the largest American Indian population outside of Alaska, primarily due to historical tribal relocation. In 2021, there were 9.7 million American Indian Alaska Native AIAN people, 10.2% were age 65 plus. American Indian and Alaska Native people rank at or near the bottom of nearly every social, health, and economic indicator. Lower life expectancy and disproportionate disease burden are a result of inadequate education, disproportionate poverty, discrimination in the delivery of health services, and cultural differences. According to Census Bureau projections, the 2020 life expectancies at birth for American Indians, Alaska Natives, are 78.4 years, with 81.1 years for women and 75.8 years for men. For non-Hispanic whites, the projected life expectancies are 80.6 years, with 82.7 years for women and 78.4 years for men. It is significant to note that American Indians, Alaska Natives frequently contend with issues that prevent them from receiving quality medical care. These issues include cultural barriers, geographic isolation, inadequate sewage disposal, and low income. Key health indicators for American Indian and Alaskan Native populations include high rates of diabetes, obesity, heart disease, chronic liver disease, unintentional injuries, suicide, substance abuse, chronic lower respiratory diseases, and higher mortality rates compared to the general population, particularly from conditions like diabetes, liver disease, and unintentional injuries. They also often experience lower access to health care and higher rates of tuberculosis compared to other racial groups. Some important factors to consider are socioeconomic disparities. Socioeconomic factors like poverty and lack of access to education can significantly impact the health of American Indian and Alaska Native populations. Cultural considerations. Culturally appropriate healthcare approaches are crucial for addressing health disparities among these populations. And tribal variations. Health concerns can vary significantly between different tribes depending on their geographic location and cultural practices. American Indian Alaska Native people rank at or near the bottom of nearly every social, health, and economic indicator. Compared to all other race or ethnic populations, AIAN populations have the highest poverty rates, 24.1%, almost twice the national rate, 12.8%. One study found that 56% of AIAN individuals across the country experienced food insecurity, with 31% reporting very low food security. In 2019, the overall unemployment rate for AIAN people was 6.1%, compared to 3.7% nationwide. According to the Bureau of Indian Affairs, in 2019, 84.4% of AIAN people, alone or in combination, had at least a high school diploma or equivalent. Housing affordability is the most common problem for AIAN households. Approximately 38% of AIAN households were cost-burdened, meaning more than 30% of their income goes towards paying for housing, compared to 36% nationally. And homelessness in tribal areas often leads to overcrowding, having more than one person per room. Social determinants of health, SDOH, have a significant impact on Indigenous health, including historical oppression. The consequences of colonization, forced migration, and oppression have led to poor health conditions, high mortality rates, and disproportionate rates of disease. Systemic discrimination. Indigenous peoples have historically had less access to mainstream services and health care, which has led to health inequities. Cultural identity. Cultural identity, family, kinship, language, and participation in cultural activities are all key determinants of health for Indigenous people. Access to resources. Access to food, water, education, land, and employment are all social characteristics that affect health outcomes. Traditional healing practices. Traditional Indigenous healing practices are often not taken into account in the design of health programs. Food insecurity. Low socioeconomic status, SES, can lead to food insecurity, which can negatively impact health. Inadequate transportation. Inadequate transportation can make it difficult for families to keep scheduled medical appointments. And unsafe neighborhoods. Unsafe neighborhoods can prevent children from playing outside. Colonial and imperialistic ideologies have shaped epidemiology and medicine in ways that have supported the colonization of Indigenous peoples, including unethical research. Early epidemiological studies were often conducted by Western researchers in colonized countries without the participation or informed consent of local communities. Colonialist tendencies. Epidemiological studies have been criticized for ignoring Indigenous health inequities and misrecognizing their causes. Colonial legacies. Epidemiological studies have highlighted the ways in which colonial legacies of discrimination shape Indigenous identities, perceptions, and experiences. And historical trauma. The health of Native people in the United States is still impacted by colonization, racism, oppression, and historical trauma. Despite early medical research abuses against Native Americans, tribe members have helped make breakthroughs for more than 50 years by participating in studies about the epidemiology, prevention, and treatment of infectious diseases, according to NIH. These studies resulted in measures to prevent morbidity and mortality, especially among children, from many diseases. Consider factors like the level of community engagement in data collection, cultural appropriateness of the measures, data accessibility, whether the data reflects a holistic view of health beyond just clinical measures, and potential biases stemming from data collection methods and researcher perspectives, while always prioritizing the inclusion of Indigenous voices and perspectives in the analysis process. Community-driven data collection. When Indigenous communities are actively involved in designing and implementing data collection methods, the data is more likely to accurately reflect their unique needs and priorities. Culturally appropriate measures. Utilizing culturally relevant concepts and language in data collection tools can lead to more meaningful and accurate information about Indigenous health. Holistic approach. Beyond just clinical data, incorporating social, cultural, and spiritual aspects of health can provide a more comprehensive understanding of well-being. And strengths-based focus. Highlighting positive aspects of Indigenous communities and resilience factors can provide a more balanced view of health. Data gaps and limited availability. Access to comprehensive and reliable data on Indigenous health can be restricted due to geographic challenges, limited funding, and lack of consistent data collection practices. Misinterpretation of data. Using standard health measures not designed for Indigenous populations can lead to misinterpretations and inaccurate conclusions about health disparities. Lack of cultural sensitivity. Data collection methods that do not consider cultural nuances or sensitivities may result in biased or unreliable information. Power imbalances in research. If Indigenous communities are not adequately involved in research design and decision-making, the data may not accurately reflect their experiences. And data aggregation issues. Aggregated data at the national level might not capture the diverse experiences and needs of different Indigenous groups within a region. Community engagement. Assess the level of community involvement in data collection, including consultation with elders, community leaders, and health workers. Cultural appropriateness. Evaluate whether the data collection methods and measures used are culturally sensitive and relevant to the specific Indigenous population. Data governance. Consider who has access to the data, how it is stored, and how Indigenous communities are involved in data sharing and interpretation. Data quality. Evaluate the reliability and validity of the data, including sample size, response rates, and methodology. And strengths-based approach. Analyze the data to identify not only areas of concern, but also strengths and resilience factors within Indigenous communities. By critically examining the strengths and limitations of available Indigenous health data, researchers and policymakers can develop more informed strategies to address health disparities and promote health equity for Indigenous populations. Culture has a significant impact on how people define and experience illness, and it can affect many aspects of healthcare. Explanation of illness. Different cultures have different explanations for illness, which can vary widely. For example, in Vietnamese culture, illness is explained by mystical beliefs about a balance of hot and cold in the body. Stigmatization. Culture determines which illnesses are stigmatized and which are not. Stigmatization can have a significant impact on the patient and the care they receive. Treatment. Culture can affect where people seek help, what types of treatment they prefer, and how they cope with symptoms. For example, people from India and Pakistan may be reluctant to accept a diagnosis of mental retardation or severe emotional illness because it could affect their family's chances of marriage. Language. Language differences can affect how symptoms are discussed, which can lead to differences in diagnosis. Patient-provider interactions. Cultural and educational differences between patients and providers can affect the quality of care. For example, African American patients often experience shorter physician-patient interactions than Caucasian patients. And health literacy. Cultural barriers can contribute to problems with health literacy. Culture can impact the diagnosis of illness in many ways, including misdiagnosis. Clinicians who don't consider a patient's cultural context may misdiagnose or miss symptoms. For example, Western clinicians may assume how depression manifests, which can differ across cultures. Cultural concepts of distress. Behaviors that are considered aberrant in one culture may be standard in another. For example, paranoid thoughts may be expected in clients who have migrated from countries with oppressive governments. Culture-bound syndromes. Some sets of symptoms are more common in some societies than in others. For example, schizophrenia is considered a culture-bound illness, with Western societies viewing it as a medical issue, and Eastern societies viewing it as a spiritual phenomenon. And explanatory models. Patients and relatives may have their own perspective on the origin of symptoms, why they occur, and how the process of getting ill has evolved. Culture can impact the treatment of illness in many ways, including health beliefs. Culture can affect how people think about health, including their beliefs about what causes illness and how to prevent it. Communication. Culture can impact how people communicate, including how they use direct versus indirect communication, and what can be discussed about health. Treatment options. Culture can impact treatment options, such as whether women request less invasive treatments. Medication responses. Culture can impact how people respond to medications, such as whether they metabolize them correctly. Coping mechanisms. Culture can impact how people cope with stress and illness, such as whether they use spiritual practices or social support networks. Acceptance of diagnosis. Culture can impact how people accept a diagnosis, including who should be told and when. Acceptance of preventive measures. Culture can impact how people accept preventive measures, such as vaccines, prenatal care, and screening tests. And perceptions of death. Culture can impact how people perceive death and dying and who should be involved. Clinicians can learn to develop treatment plans that are respectful of their patients' cultures. The National Standards for Culturally and Linguistically Appropriate Services in Health and Healthcare, CLAS standards, can help improve quality and eliminate healthcare disparities. Culture can have a significant impact on how people think about health and illness, and how they prevent and respond to health issues. Healthcare. Culture can influence how people seek healthcare and how they respond to healthcare interventions. Culture can also affect how people accept diagnoses and who they tell about their diagnosis. Family dynamics. Culture can be influenced by family dynamics such as gender roles, filial responsibilities, and patterns of support. Disease spread. Culture can play a large role in how infectious diseases spread through communities. Health system access. Culture can affect how accessible people find the health system and how well it functions. And treatment plans. Clinicians can develop treatment plans that are respectful of a patient's culture. The key principles of successful health surveillance are important because they help to ensure that public health surveillance systems are effective and produce actionable results. The key objective of surveillance is to provide information to guide interventions. The public health objectives and actions needed to make successful interventions determine the design and implementation of surveillance systems. In the Great Plains area, AIAN health surveillance falls within the scope of the Great Plains Tribal Leaders Health Board. One of the functions of the board is to provide Great Plains area tribes with reports of timely, accurate, and useful data on public health priorities based upon existing data sources and contribute to the effective use of this data. Additionally, the board aims to improve the ability of surveillance systems to measure and monitor the health status of American Indian populations through effective utilization of existing tracking or surveillance systems and/or development of new surveillance activities. Support evidence-based, culturally rooted health promotion and disease prevention initiatives in clinical and community contexts. Build capacity to conduct health research in collaboration with academic institutions, including tribal community colleges and tribal schools, to maximize the benefits of well-designed, culturally appropriate, and ethical health research in Great Plains area tribal communities. And build and leverage effective partnerships and respond to emergent needs with training and technical assistance to contribute to the growth of public health and epidemiologic capacity and excellence within the Great Plains area, especially within tribal communities. This work is performed by the board's Tribal Epidemiology Center Tech Department. GPTEC's mission is to provide leadership, technical assistance, support, and advocacy to tribal nations and communities in the Great Plains to eliminate the disparities in health that currently exist for tribal people in the area. The center works in partnership with the Indigenous communities to provide statewide and regional level data to tribal health organizations and other entities working to improve the health of AIAN people. Tech staff author manuscripts on public health topics, which are published in peer-reviewed journals to inform others interested in improving AIAN health. Techs provide data analysis, data surveillance, and epidemiologic services, and produce data products for monitoring, evaluating, and advocating for the health and wellness of AIAN peoples. Tribal leaders with the valuable data and information they need to make informed, health-based decisions for the people they serve. The Tribal Epidemiology Center performs these 7 core functions as per the 1992 Indian Healthcare Improvement Act: collecting data and monitoring health, evaluating data and healthcare delivery systems, identifying health priorities, making recommendations for health service needs, making recommendations for improving healthcare delivery systems, providing epidemiologic and other technical assistance, and providing disease surveillance. The tech implements these 7 core functions by compiling, collecting, and disseminating tribal public health data, providing epidemiological evaluation and other public health support, assessing, summarizing, and responding to tribal health priorities and needs, responding to public health outbreaks and emergencies affecting tribal communities, guiding and supporting change within public health and clinical systems, and growing GPTEC as a public health resource. Here are a few vital points to reflect on when you consider how social determinants of health differ in AIAN communities. AIAN, people experience unique challenges because of the history and effects of colonization and subsequent treaties with the United States government. Be careful not to discount the significance of how historical trauma has affected populations physiologically. AIAN, people have distinct values and perspectives that are often tied to the land and traditions that date back hundreds of years. They were the first people populating the United States. Members of the AIAN community value respect and humility. Communication is more subtle and thought through. Direct or confrontational communication styles are often perceived as of and disrespectful. As a result, a patient may choose not to share important information out of shame or embarrassment. The family unit is the center of life in the AIAN community, and elders are treated with reverence. Adult patients may bring a parent or grandparent to appointments to act as a decision maker, because as the younger generation looks to them for wisdom and guidance. Here are our resources. Thank you.